Assalamualaikum students, a very good morning to you all. I hope you all are fine. So before the lockdown, we started drugs for dyslipidemia, and Professor Maqsood Ahmed Saab, he taught you about different types of lipoproteins, different types of primary hyperlipidemia, secondary causes of hyperlipidemias, their management and how to diagnose dyslipidemias, that is by overnight fast, and what are the normal levels of different lipoproteins. So you have been done with the statins and you started niacin. So we'll continue with niacin today and then we'll summarize the whole lecture. So I want you to keep your notebooks by your side and note down the important points. So let's get started.
Let's revise the classification of the drugs used to treat dyslipidemias. There are 5 groups of drugs or classes of drugs which are used to treat hyperlipidemias. The first one is HMG-CoA reductase inhibitor. These drugs are also called statins, and all of these drugs have statin as a suffix in their name, so it is easy to remember their names. Atorvastatin and rosuvastatin are long-acting, therefore they can be given at any time during the day, and the rest of the drugs are usually given at bedtime. The next drug is niacin, which is vitamin B3, and these two drugs, they primarily target the LDL cholesterol. They also increase HDL and decrease VLDL, but mainly they target the LDL cholesterol. Next group is fibrates, and the drugs are fenofibrate and gemfibrozil. You can see fib in their name, so you can guess that these drugs belong to the group fibrates, fenofibrate and gemfibrozil, and they primarily target the triglycerides, VLDL. Bile acid sequestrants, cholestyramine, cholestyramine, cholcevilam, they all have cholest in their names, which means they are affecting cholesterol. And the last one is cholesterol absorption inhibitor, that is ezetimibe, and it also decreases LDL cholesterol. Bile acid sequestrants, they also decrease LDL cholesterol. Fibrates, they act primarily on the triglycerides. Let's check out the learning objectives for today's session. By the end of today's lecture, you should be able to classify the drugs used to treat dyslipidemias, and we have already discussed them, and enumerate their mechanism of action, uses, adverse effects, and also write different combination therapies for treatment of hyperlipidemia. Niacin is vitamin B3 and it is given orally. In the body, it is converted to nicotinamide, which is incorporated to cofactor NAD, and without its incorporation into NAD, it is not functional. And niacin, its nicotinamide derivative and other metabolites, they are excreted in urine. Like statins, niacin also decreases VLDL, LDL, and increases HDL cholesterol. Now let's check out how it is doing that. Niacin inhibits the lipolysis in adipose tissue, and this lipolysis was required for production of free fatty acids, and as you know, liver uses free fatty acids for triglyceride synthesis, which is required for production of VLDL. So in this way, the production of VLDL is decreased, and as you know, VLDL is the precursor of LDL, therefore LDL is also decreased. And niacin also increases the clearance of plasma VLDL lipoprotein lipases, and it decreases the catabolism of HDL and thus increases the level of HDL cholesterol. So let's try to understand its mechanism with the help of the diagram. So what it was doing, it is acting in the adipose tissue. What it is doing, it is inhibiting the conversion of triacylglycerol to fatty acids, means it is inhibiting the production of fatty acids in the adipose tissue. And these fatty acids, they were required for the synthesis of triacylglycerol inside the liver for the production of VLDL. So no fatty acids, no VLDL, and no VLDL, no LDL. So in this way, it is decreasing the VLDL and LDL cholesterol, and it also inhibits the catabolism of HDL cholesterol. So what are its pharmacological actions? It decreases VLDL by decreasing its synthesis in liver and by increasing its clearance in plasma by lipoprotein lipase. and decreases LDL due to reduction in its precursor. It induces modest increase in HDL cholesterol by inhibiting its cation, and it increases tissue plasminogen activator levels and decreases fibrinogen, thus reverses endothelial dysfunction. So niacin is the most effective medication for increasing HDL cholesterol levels, and it has positive effects on the complete lipid profile. So it is useful for patients with mixed dyslipidemias. You can get this in MCQ that it is the most effective medication for increasing HDL. It increases HDL by 20 to 30%, and it is the only agent that reduces lipoprotein A. This is also an important MCQ. And it is also used to treat hypercholesterolemia caused by nephrosis. So the important points to remember are that it increases HDL to the maximum as compared to other drugs, and it is the only agent that reduces lipoprotein A. Niacin has so many adverse effects, and that's why they are often asked in exams. So you have to remember them. It produces harmless cutaneous flush. The patient might experience vasodilation and warmth, and you have to tell them that it is harmless, and tachyphylaxis to this flushing will develop within a few days. But if it is disturbing the patient, you can ask them to take aspirin 1.5 hours before niacin or ibuprofen once daily, and this flushing results from stimulation of prostaglandins by subcutaneous Langerhans cells via the niacin receptors. That's why they can be blocked by aspirin, because this is due to stimulation of prostaglandins. And they can complain of pruritus, which is itching, rash, dry skin, and pruritus and rash is due to histamine release. And acanthosis nigricans, it is due to insulin resistance. This is acanthosis nigricans. These are hyperpigmented hyperkeratotic plaques in the skin folds. This is the nape of the neck, and this is the underarms. It can cause nausea, abdominal discomfort, hepatotoxicity. It can impair carbohydrate tolerance due to increase in insulin resistance. Can produce hyperuricemia because it inhibits the tubular secretion of uric acid. So if a patient is having gout, you won't give him niacin. It can produce red cell macrocytosis, reversible platelet deficiency, arrhythmias, and macular edema. The patient will report blurring of distant vision. So these are the adverse effects, and you have to memorize them because these are often asked in the. It is contraindicated in gout because it inhibits the tubular secretion of uric acid and produces hyperuricemia. It is contraindicated in peptic ulcer because it stimulates histamine release, which will increase the gastric acid production, in hepatotoxicity, and if a patient is having acanthosis nigricans. And if the patient develops acanthosis nigricans due to niacin, you immediately stop the drug. So let's discuss fibrates. Gemfibrozil is absorbed from intestine, and its absorption increases with food. It is tightly bound to plasma protein and crosses placenta. Its half-life is 1.5 hours, and 70% is eliminated through kidneys. Whereas fenofibrate is hydrolyzed completely in intestine, its half-life is 20 hours, 60% is excreted in urine as glucuronide, and 25% in feces. The mechanism of action of fibrates is very important. They are basically ligands for PPAR alpha receptors, which are peroxisome proliferator activated receptor alpha. But before checking out their mechanism of action, you must know what are peroxisome proliferator activated receptors. These are intracellular receptors, and these are group of nuclear receptor proteins that function as transcription factors and regulate the expression of genes. So upon binding to these receptors get activated, and they regulate the expression of genes responsible for upregulation of lipoprotein lipase, ApoA1 and ApoA2. ApoA1 and ApoA2 are apoproteins of HDL cholesterol, and they also cause downregulation of ApoC3 protein, and this is the protein which inhibits lipolysis. So this is their mechanism of action. The main thing that you need to know is that they are activating PPAR alpha receptors. There are different types of peroxisome proliferator activated receptors, alpha, delta, gamma, and alpha are the ones which modulate fat metabolism. So let's revise it again. Fibrates, they activate PPAR alpha receptors and regulate the expression of genes responsible for upregulation of lipoprotein lipase ApoA1 and ApoA2, and downregulate ApoC3, which inhibits lipolysis. So they will increase HDL cholesterol and they will decrease LDL cholesterol and VLDL, and because they're down regulating the protein which is inhibiting lipolysis, so they will increase lipolysis. They also increase the oxidation of fatty acids in liver and striated muscles, and increased activity of plasma lipoprotein lipase will hydrolyze VLDL and chylomicrons, and thus it will decrease serum triglycerides. So the uptake of LDL will be increased by the liver. You can see here that fatty acid oxidation is increased in the skeletal muscle, and the plasma lipoprotein lipase activity is increased because it is upregulating the genes responsible for production of lipoprotein lipases, and there is more hydrolysis of VLDL and chylomicrons, therefore triglycerides will be decreased. And inside the liver, it is increasing the ApoA1, ApoA2 synthesis, which leads to increase in HDL cholesterol, and it decreases ApoC3 synthesis. And it decreases the synthesis of triglycerides, and in liver also it causes oxidation of fatty acids. So basically its mechanism of action is that it activates peroxisome proliferator activated receptor alpha, PPAR alpha. Since the primary target of fibrates are VLDL, very low density lipoproteins, and their major component is triglycerides, therefore they are primarily used in the treatment of hypertriglyceridemia, in which VLDL predominates. They're also used in treatment of dys-beta lipoproteinemia and in hypertriglyceridemia due to viral protease inhibitors. So if you get a case in which a person is having high triglyceride levels, but his cholesterol levels are normal, then you will prescribe fibrates to that patient. Whereas statins and niacin can be given in both cases. If cholesterol and triglycerides both are elevated, then those drugs can be given. Their adverse effects are also very common. They can cause GI upset and rashes, and like statins, they can cause myopathy, rhabdomyolysis, and hepatotoxicity. They can also decrease WBC count, and they increase the risk for gallstones as well. They increase the risk of myopathy when combined with statins. Therefore, they are usually not given in combination therapy with statins, and they potentiate the actions of oral anticoagulants and sulfonylureas because they are bound to plasma proteins and they displace these drugs from the plasma proteins. They are contraindicated in severe hepatic or renal dysfunction and in pre-existing gallbladder disease because they can produce gallstones, which are also known as cholelithiasis, and they are also contraindicated in pregnancy.
The next group is bile acid sequestrants or bile acid binding resins.
These are orally given, but they are neither absorbed nor metabolically altered by the intestine, and they are totally excreted in feces. They are large molecules insoluble in water, and they are usually taken with meals. Before discussing the mechanism of action of bile acid sequestrants or bile acid binding resins, let's check out what actually bile is. You all know that bile is manufactured in the liver or made in the liver from cholesterol, and then it is stored in the gallbladder, from where it goes to the intestine, and it emulsifies fats and helps in absorption of fat. Clear? All the bile from the gallbladder, it goes to the intestine and it binds to fat molecules and helps in their absorption. And almost 97% of this bile is reused. It again comes to the gallbladder and it is stored over there. So this is important to know the mechanism of action of bile acid sequestrants. These bile acid sequestrants or bile acid binding resins, they bind to the bile in the small intestine and inhibit its reabsorption. and in this way the bile is excreted out in feces. These are bile acid binding resins, and they bind to the bile and inhibit its reabsorption, and it is excreted out in feces. So the liver gets signal to synthesize more bile, and as you know, bile is synthesized from cholesterol, so liver will use its cholesterol to synthesize more and more bile. And in this way, the intrahepatic stores of cholesterol will decrease. And as we discussed during the mechanism of action of statins, that when intrahepatic stores or concentration of cholesterol decreases, it transcriptionally increases the upregulation of LDL receptors, and it will synthesize more and more LDL receptors, which will promote the uptake of plasma LDL, and in this way they will decrease LDL cholesterol. So in this way, bile acid binding resins will decrease the levels of LDL cholesterol. Now let's discuss that mechanism. Bile acid binding resins are basically cation exchange resins. They bind bile acids and salts in the intestinal lumen, forming complex which is excreted in feces, preventing bile acid returning to the liver by enterohepatic circulation. That we have discussed, that these bile acid binding resins, they will bind to the bile acids and salts inside the small intestine, and they will inhibit its return to the liver by enterohepatic circulation. And loss of bile acids in the stools will increase the conversion of cholesterol into bile acids in the liver, which will decrease the concentration of intrahepatic cholesterol. That will lead to compensatory increase in LDL receptors, and thus the hepatic uptake of circulating LDL will be increased and serum LDL cholesterol levels will decrease. Clear? So this is what's happening normally. We have already discussed it, but let's revise it. That bile salts and bile acids are synthesized from cholesterol in the liver, and these bile acids, they are stored in gallbladder, and when needed they go to the small intestine where they emulsify fats, and then they are reabsorbed. But what happens when we give bile acid binding resins? They will bind the bile acids and salts in the intestine, and they will form insoluble complex, and they won't get reabsorbed, and they will be excreted out in feces. And the liver will utilize more and more cholesterol to form bile salts. The intrahepatic stores of cholesterol will decrease. There will be upregulation of LDL receptors, and will promote the binding of plasma LDL, and in this way LDL cholesterol levels will decrease. So pharmacological actions, their effect on LDL cholesterol is that it decreases cholesterol content of hepatocytes, leading to upregulation of LDL receptors with increased LDL cholesterol clearance from blood and decreased LDL cholesterol levels, that we have already discussed. This is a very important point to remember, that it produces transient increase in triglyceride levels in normal subjects, which return to baseline. But in borderline patients, for example, if their triglycerides are more than 250 milligrams per deciliter, it produces marked increased triglycerides, which is dangerous. So if you get a case in which a patient is also having hypertriglyceridemia and he's also having hypercholesterolemia, you will never give bile acid binding resins to that patient, because it will increase the level of triglycerides. So since they can increase the level of triglycerides, they are used in treatment of primary hypercholesterolemia only, and they can also be used to treat pruritus due to biliary obstruction. They cannot be given to the patients with mixed hyperlipidemia or hypertriglyceridemia. And since they bind the digoxin, they can also be used in digitalis toxicity, and they decrease absorption of a list of drugs, because they will bind them and they will decrease their absorption. So they have these drugs have to be given 1 hour before or 2 hours after the resins. Colsavilam, it does not bind HMG-CoA reductase inhibitors, warfarin or digoxin, so it will not decrease their absorption, as they were cationic binding resins, exchange resins. Therefore they affect the absorption of these drugs. They affect the absorption of neutral drugs, anions, all of them. Their main adverse effect is constipation and bloating. It occurs in a lot of patients. In some patients having pre-existing intestinal diseases, they can produce steatorrhea, and they can inhibit the absorption of vitamin K, leading to hypoprothrombinemia. So if a person is also taking anticoagulants and we have to give him raisins, we should monitor his PT levels. It can also cause malabsorption of folic acid, and the increased formation of gallstones, especially in obese. So bile acid binding raisins and fibrates, they both can lead to cholelithiasis. They are contraindicated in persons with diverticulitis or complete biliary obstruction, because in cases of biliary obstruction, bile is not secreted into the intestine. So till now we are done with 4 groups: statins, niacin, fibrates, and bile acid binding raisins. Niacin and statins, they decreased LDL cholesterol and VLDL as well, and they increased HDL cholesterol. And niacin also decreased lipoprotein A. Whereas fibrates, they mainly targeted the VLDL cholesterol because they decreased the level of triglycerides mainly. And raisins and cholesterol absorption inhibitors, they basically decrease the level of LDL cholesterol. Ezetimibe is conjugated in intestine to active glucuronide, and it undergoes enterohepatic circulation. It has a long half-life of 22 hours, therefore it is given once daily. 80% is excreted in feces, and its plasma concentration is increased with fibrates and decreased with cholestyramine, as we have seen earlier that cholestyramine, which was bile acid binding raisin, it decreases its absorption. And it has synergistic action with HMG-CoA reductase inhibitors, because the reductase inhibitors are decreasing the endogenous cholesterol synthesis, and ezetimibe are cholesterol absorption inhibitors, so they will decrease the absorption of exogenous cholesterol. Ezetimibe inhibits the dietary and biliary cholesterol absorption at the brush border of the intestines, leading to decreased delivery of cholesterol to the liver by blocking the NPC1L1 transport proteins. So, uh, it will decrease the delivery of cholesterol to liver, which will in turn upregulate the LDL receptor and will trap more and more LDL particles from the blood. So whenever the intrahepatic pool of cholesterol decreases, it causes the upregulation of LDL receptors and promotes the uptake of LDL from the plasma. So the thing you need to remember is that it inhibits the dietary and biliary cholesterol absorption, leading to decreased delivery of cholesterol to liver, and then the same cycle will begin and it will decrease LDL cholesterol. So basically they are used in the treatment of hypercholesterolemia because they have no effect on triglycerides or VLDL. So ezetimibe is used in the treatment of hypercholesterolemia. It has a very good adverse effect profile. It has minimal adverse effects. That's why it is mostly used nowadays, especially in combination with statins. It can produce reversible impaired hepatic function and myositis though, and is contraindicated in patients with hepatic insufficiency. So we usually use combination therapy to achieve the maximum lowering possible with minimum toxicity, because if we will add 2 groups, we can give them in low doses instead of increasing dose of a single drug group and getting so many adverse effects. So we can achieve maximum lowering of lipids with minimum toxicity by combining different drugs. And always remember, if you have to give more than one drug, you always choose the drugs from different groups. You can't do that. You add atorva and simvastatin. That's not possible. Okay, you have to choose drug from a different group. So what usually happens if there is no improvement within 6 weeks with a single drug therapy? Firstly, the dose should be increased. And still, if there is no improvement even after 3 months, then change the drug or consider combination therapy. For example, if you started the patient on statins and you have started it on a low dose like 10 milligram, and after 6 weeks, if there is no improvement in the plasma lipid profile, then you will increase the dose. And if still there is no improvement after 3 months, then you can change the drug, like you can switch to niacin or some other group, or you can give a combination therapy. So there are these three combinations which are most commonly used nowadays. The most commonly used combination is of ezetimibe with statins, mostly simvastatin, because they have synergistic effects. As we discussed earlier, that statins are decreasing the endogenous synthesis of cholesterol and ezetimibe is inhibiting the absorption of cholesterol. There is also a combination of bile acid raisins with statins or of bile acid raisins with niacin. Fibrates and statins are usually contraindicated because they can produce myopathy. But if you have to give a fibrate with a statin, fenofibrate is the fibrate which can be given along with the statins. Then niacin should be used cautiously with statins because it can cause myopathy. But these two combinations are usually avoided. The most commonly used combinations are of ezetimibe and statins, bile acid raisins with statins, bile acid raisins with niacin, and bile acid raisins with fibrates too. They are also used. Now let's summarize whatever we have done. We have discussed 5 groups. HMG CoA reductase inhibitors or statins, niacin, fibrates, bile acid binding raisins, and cholesterol absorption inhibitor, that is ezetimibe. Statins, basically they have maximum effect on decreasing LDL cholesterol. They also decrease triglycerides and increase HDL. Niacin has maximum HDL increasing effect, and it also decreases lipoprotein A, and it will decrease LDL and triglycerides as well. Fibrates have maximum lowering effect on the triglycerides. However, they also decrease LDL and increase HDL. Bile acid binding raisins have effect on LDL cholesterol. They have minimal effect on triglycerides, or they can even slightly increase the triglycerides. And cholesterol absorption inhibitors, they just decrease LDL cholesterol. So this is really important. If you get a lipid profile of a patient by knowing which drugs are acting on which component of the lipoproteins, you can easily suggest a drug for the treatment. Then we should revise the adverse effects of these drugs because these are commonly asked in the exams. So myopathy, rhabdomyolysis, myoglobinuria, and C is creatine kinase more than 10 times is adverse effect of statins. Also produces hepatotoxicity. The LFTs are deranged. They are increased 3 times than the baseline, and these are teratogenic, the HMG CoA reductase inhibitors. Then flushing, pruritus, increased uric acid level, and hepatotoxicity are the common adverse effects of niacin. And this flushing is due to production of prostaglandins, and it can be inhibited either by taking at bedtime because patient won't notice it, or if it is still bothering the patient, then he can take aspirin or ibuprofen. And for pruritus, the patient can take antihistamines because pruritus is due to release of histamine, and pruritus means itching. Hepatotoxicity, myopathy, cholelithiasis, and nausea are the adverse effects of fibrates mainly. And they are not given with statins because they will increase the risk of hepatotoxicity and myopathy. And if a statin has to be given with fibrate, it can be given with fenofibrate. And these drugs should be avoided in patients with liver disease and gallbladder disease. Constipation and bloating are the main adverse effects of bile acid binding raisins. And ezetimibe has a very good safety profile. It has little adverse effects. It can also produce myopathy and hepatotoxicity, but in very rare cases. Now it's the quiz time. You have to write down the question number and their answers. You don't have to write down the statements, okay? Increased serum levels of which of the following is associated with decreased risk of atherosclerosis? If the patient has a history of gout, which of the following drugs is most likely to exacerbate this condition? During treatment with atorvastatin, it is important to routinely monitor serum concentrations of which of the following? Which of the following is a major toxicity associated with gemfibrozil therapy? Well, that's all for today. I hope you understood the lecture well. If you have any question, you can send me a message in your WhatsApp group, or you can directly message me as well, and I will get back to you as soon as possible. Go through the lecture properly. Take care of yourselves. Have a great day. Allah Hafiz.